Hello दोस्तों, this is Karan Prajapati, MBBS student from Government Medical College. In this video, I'll be discussing endocrine system chapter of pathology and a very important topic from this, that is hypothyroidism. Few topics that are more frequently asked in the exam. So in this video, we'll be discussing one of the important question or important topic of it, that is hypothyroidism. Now the topics to be covered in this video are clinical manifestation, diagnosis, types, and most important, Graves disease, from which you can expect the question to be asked. So let's begin this video with clinical manifestation. Now, if a patient comes to you in the OPD, he or she will be having some clinical manifestations like increase in basal metabolic rate. If the basal metabolic rate is high, then obviously more fats will be burned, more calories will be burned, so weight loss. Third, cardiac problems like increased cardiac output, tachycardia. Also, a resting tachycardia means in the resting stage he will be having tachycardia, increase in heart rate. Also, arrhythmias. Fourth, GI problems like increased stool frequency due to increased mobility of the gastrointestinal tract. He or she will be having diarrhea. Eye problems like eyelid retraction, which will be giving staring appearance, most commonly seen manifestation in the patients of hyperthyroidism. 6. Skeletal problems like increased frequency of fractures, means they are more prone to increased frequency of fractures. 7. Thyroid stone. A sudden onset of hyperthyroidism may occur if thyroid stones are formed. So these are the clinical manifestation of hyperthyroidism. Now let's move on to the diagnosis part. Once you are suspecting hyperthyroidism in the patient, on the basis of certain criteria, you have to confirm that it is hyperthyroidism or something else. Now the first point is free T3 and T4 level is elevated. Second, serum TSH level estimation. We will see if the TSH level is increased or decreased. It is often decreased in the cases of Graves disease. Third, measurement of radioactive iodine uptake. Now the iodine uptake can be of three types. Let's see its type. First one is diffuse uptake. Diffuse uptake means uptake is uniformly throughout the gland. So if the report says it is a diffuse uptake, the diagnosis will be Graves disease. Second, increase uptake in single nodule. If there is increased uptake in single nodule of the thyroid gland, the diagnosis will be toxic adenoma. In case of adenoma, there is increased uptake in the single nodules occurs. Decreased uptake, then the diagnosis will be thyroid inflammation. Now let's see the types of hyperthyroidism. So basically it is of two types. First, primary hyperthyroidism. We say the hyperthyroidism is primary when the cause is inside the thyroid gland. For example, if there is tumor of thyroid gland, the cause is inside the thyroid gland, so it will fall under the category of primary hyperthyroidism. But in such cases where the cause is outside the thyroid gland, for example, adenoma of pituitary gland will lead to increased secretion of TSH and will cause hyperthyroidism. So cause is outside the thyroid gland, so it will fall under the secondary hyperthyroidism. Now one more topic is important in hyperthyroidism, that is thyrotoxicosis. So what thyrotoxicosis? So it is a hypermetabolic state which is caused by elevated circulating level of free T3 and T4. So now what is the difference between hyperthyroidism and thyrotoxicosis? So thyrotoxicosis, you can understand it it is the result. It is a result of increase in T3 and T4 level which affect the body. So it is the hypermetabolic state which is achieved due to increased level of T3 and T4. So what are the causes of thyrotoxicosis? So it may be associated with hyperthyroidism or it may not be associated with hyperthyroidism. So if it is associated with hyperthyroidism, it may be of two types, as we studied primary hyperthyroidism and secondary hyperthyroidism. So first five points will come under the primary hyperthyroidism and the fifth one will fall in secondary hyperthyroidism. Diffuse hyperplasia, that is Graves disease, toxic multinodular goiter, toxic adenoma and iodine induced hyperthyroidism, this will all fall under the primary hyperthyroidism. Why? Because the cause is inside the thyroid gland itself. Now the sixth point we can see TSH secreting pituitary adenoma. Adenoma is present where? In the pituitary. So it will fall under the category of secondary hyperthyroidism. As there are some causes which are not linked to hyperthyroidism but still causes hypermetabolic state, like granulomatous thyroiditis. It is the inflammation of thyroid gland. Lymphocytic thyroiditis, stroma ovary, exogenous thyroxine intake. In such cases, hypermetabolic state can also be achieved. Now let's study the Graves disease, the most important part of hyperthyroidism, and you can expect a question from this in your university exam or short note or as a long question. Let's begin with the introduction. So it is the most common form of hyperthyroidism. Remember hyperthyroidism. So how will you confirm that it is a Graves disease and not normal hyperthyroidism? So there comes a triad of finding. First, hyperthyroidism. Second, infiltrative ophthalmopathy. Third, infiltrative dermopathy. Now, how will you remember this? I have made a mnemonics: hyperthyroidism H, ophthalmopathy O, and infiltrative D, HOD. You can learn it like HOD. HOD has Graves disease. So in this way, you can remember this. So most common age group affected are between 20 to 40 years of age, and women are more affected than men. 10 female pay 1 male, something like this ratio. Now etiology or cause of Graves disease. So there may be basically two causes. First one is genetic cause and second one is autoimmune cause. So genetic cause, genes like CTL4, cytotoxic T lymphocyte associated antigen 4, or PTP22 gene, that is protein tyrosine phosphatase 22 gene. So if mutation occur in this gene, this will lead to Graves disease. Now second point, autoantibody. So autoantibody and pathogenesis are similar, so they will be considered. So they will be taught in the next slide. Now, pathogenesis and autoantibody. So what happens in the Graves disease? So what happens in Graves disease? There is failure of self-tolerance of the body toward thyroid autoantigens. So what happens? Multiple antibodies, autoantibodies are formed against the thyroid autoantigens. So these antibodies are of three types which are formed against the autoantigens of the thyroid gland. First one is thyroid stimulating immunoglobulins. Immunoglobulins, mainly IgG antibodies, bind to the TSH receptor. So action becomes, it acts as an agonist and stimulates the TSH receptor to production of thyroxine, which lead to hyperthyroidism. Second, thyroid growth stimulating immunoglobulin. It is also directed against TSH receptor. So action becomes, so it causes proliferation of thyroid follicular cell leading to diffuse hyperplasia of thyroid gland. Hyperplasia means increase in number of cells of so due to increase in number of follicular cell, so obviously there will be more synthesis of T3 and T4 level, which will ultimately cause hyperthyroidism. Now the third antibody, that is TSH binding inhibitor immunoglobulin. So it prevent the binding of normal TSH to TSH receptor. So it may cause three. First, stimulation, inhibition, and if stimulation occurs to some cells, it will cause hyperthyroidism. If some cells are inhibited, it will cause hypothyroidism, and both can also coexist. So if both coexist, then there will be alternate episodes of hyperthyroidism and hypothyroidism. Now let's study microscopy. So gross feature, thyroid gland is symmetrical enlarged. So in this remember this word, symmetrically enlarged. Since the thyroid gland is enlarged, so obviously weight will be increased. Now microscopy. First point, increase in crowding of cuboidal epithelial. As you can see, these are the follicular cell. There will be more crowding like this. So increase in crowding of the cuboidal epithelium will occur. Presence of small papilla without fibrovascular coat. Remember, without. Third point, lymphocytic infiltration into the interstitium. Now let's see the clinical features of Graves disease. First, ophthalmopathy. It will cause abnormal protrusion of eyeball, which will give a staring appearance. Infiltration ophthalmopathy, characterized by increased volume of retroorbital connective tissue. In the retroorbital portion, means behind the eyeball, there will be increased volume, staring gauge with lid retraction due to sympathetic overactivity. Dermopathy. It is related to skin. So it is found in the skin of leg. most commonly seen in skin of leg. So what happens is that skin becomes scaly and thickened, and this is caused due to deposition of glycosaminoglycan and infiltration of lymphocytes. So these are the main features of Graves disease, and plus all other features of hyperthyroidism, as we have already discussed earlier in this video. So what are the lab finding? So what are the lab findings in case of Graves disease and how it is different from normal hyperthyroidism case? So increase in T3 and T4 level in blood, as we have already seen in case of hyperthyroidism, it is necessary. See why, see how. It is a case of hyperthyroidism, and hyperthyroidism is due to increased level of T3 and T4. So whether it is a normal case of hyperthyroidism or Graves disease, it is must that there will be elevated level of T3 and T4 level in blood. Now, what is different here is decreased TSH level. Decreased TSH level will tell you that it is a case of Graves disease. Now, as we have already discussed, in case of Graves disease, radioactive iodine uptake will be of diffuse type. So we have completed the first part of this chapter, endocrine system, one of the most important topic, that is Graves disease and hyperthyroidism. In the next videos, I'll be discussing hyperthyroidism, Hashimoto disease, and inflammation of thyroid gland, from which questions, long question or short questions, are more often asked. So if you really like this video, please consider subscribing to our channel